All right, welcome to session 2 of day 2 of TIO Global 2026. And we're now moving from structural heart disease to complex PCI. And our colleague Benjamin Seguy and Guillaume Bonnet from Bordeaux, they will guide us through a complex PCI case. But before we do that, let me open the next poll question. So coronary calcium modification. Technologies like intravascular lithotripsy and orbital or rotational atherectomy. What is your stand on that? Is it overrated? Because a non-compliant balloon will do the trick in most cases. Second option, should it be available in all PCI cath labs regardless of case volume? Third, well, all these technologies can be used interchangeably. D, should only be used with invasive imaging guidance to achieve optimal results. Or E, none of the above. Again, take some time to answer this question. In the meantime, I will walk you through the slides and the case presentation. So we're now talking about an 85-year-old patient here in Bordeaux who is quite an active gentleman and had a recent PCI to his circumflex artery. The patient still has some angina. He has a history of paroxysmal atrial fibrillation, preserved ejection fraction, no valvular disease, and he has also there was also a SPECT that demonstrated ongoing ischemia. So this is angio that is not running, but doesn't worry, it's a left dominant system. But you see the FFR evaluation of the left main LAD, and there's a clear depressed FFR of 0.63, and also a jump of the gradient at the level of the proximal segment of the LAD. So let's see how the team will manage and interpret those coronary physiology data. So they did, as mentioned, PCI of the circumflex a couple of weeks earlier. Probably based on what I can tell here, there is some maybe stent under expansion. Let's see if they are going to tackle that. And with that, they're going to treat now the LAD. It's going to be an imaging-guided procedure where the plan is also to consider calcium modification with orbital atherectomy. With that, we go back to the results of the poll. So what is the audience thinking about these devices, these calcium modification devices? Can you bring the poll up, please? Well, that's quite interesting. Only a very, very minor part of the audience thinks it's overrated. And a third of the people believe that, well, you need to use these devices with imaging guidance. And then the majority, 45%, should claim that it should be available. These technologies should be available in all cath labs, regardless of case volume. Mohamed, what is your take on this? Are these technologies, do they need to be ubiquitous, or should it be reserved to the so-called centers of excellence?
What you are going to do, correct? So if you are in a center and you want to treat these patients, you want to treat patients with coronary calcification, then you have to have these tools. Maybe not all of them, but you have to have the majority of them. And if you're in a center where you say, okay, when I encounter these patients, I will just send them away, then it's fine if you don't have them. But you can't, the problem would be to say, okay, I'm going to tackle these lesions, but without these tools. This would be a mistake, I would say.
Mm-hmm, mm-hmm. And Rui, what is your take on this? Does every site need to have orbital or rotational atherectomy, or is intravascular lithotripsy maybe a more attractive technology to be more dispersed? What is your take?
Oh, well, Mohamed and Nico, it's a pleasure to be here again. I believe that it's not doable to have a coronary program without this sort of therapies. If you think about the last atlas of ERPCI that was published, 94% of the interventional cardiology activity in Europe, in 58 countries, is still PCI. So that is dominant in most of the centers. And if you think that if you want to offer a patient all the possibilities when you are competing with surgery in some cases, not in all cases, of course you have to have the tools that make the procedure possible. Of course, then some data might be disputable regarding what you can achieve with orbital, rota, lithotripsy versus just high pressure balloons. But I think it's also in the hands of the operator that are experienced to select the proper tools that he is used to do so that he can overcome some particular situations. So I think if you have a patient like this 3-vessel and then it's calcified and you don't have these sort of tools, maybe you don't have you cannot offer him percutaneous approach, and you have to send him elsewhere or to a different center just to perform surgery. And for me, that is not really appropriate. I think we need to have everything on board so that we can offer patients the full range of options that we have in our community at this stage.
Yeah, I think we have a consensus here among the panelists, and I think it's an important nuance that we also bring. So if you want to tackle calcific coronary artery disease, yes, you need to have these technologies on the shelf, but that doesn't mean that you have to use it all the time. So it all revolves around patient selection, and this is where probably also invasive imaging comes into the picture. So to all the cynics who say, yeah, but all the randomized controlled studies comparing balloons with these advanced technologies have been negative. Well, my take on those trials like Eclipse and Shortcut and others and Sonar is that, well, it is not, you need to select your patient properly. And there are some patients where you just should not be starting without atherectomy. And there are also some patients that have an amount of calcium that really require modification with intravascular lithotripsy. It is just not to be used in all patients. With that said, I think it's high time to go to the cath lab where Guillaume and Benjamin are waiting for us. So guys, welcome to day 2 of TIO 2026 Global. Tell me, what have you been up to so far in this patient? And yeah, the floor is
hi
yours.
everybody. Yeah, very happy to be here at TIO. So Benjamin, Guillaume, André are our fellows that will do the IVUS, and we have all the nursing team with Laetitia, Christelle, and David. So far we've been, thanks for the excellent presentation, it's excellent discussion so far. So first we show you the setting. So we are radial. I think most of our complex PCI are radial. We're using a 7 French that gives you all the option. It was very easy to use to have the EBU 3.5 in the left main using the right radial. And so first what we did was putting a wire in the circumflex. And André will show you the IVUS of the stent that we put 2 weeks ago in the circumflex. So go ahead, André.
So what we see going from the distal part of the artery is that the artery is diffusely diseased, but the stent, actually there's no edge dissection, the stent is well expanded, and there's no malapposition, and the size of the stent, it's like 3.5, which is the actual size of the stent, so it's well expanded. So quite a good result, despite of the aspect that we saw earlier on the stent boosting technique.
So the underimpression we see on the angio and the circumflex was not an IVUS problem, so we decided to keep it that way. It doesn't need to optimize.
Yeah.
Now you can see the angio. This is the cranio angio. You can see that the LAD is a very diffused LAD. What we decided in this patient was to treat the proximal lesion. You remember that the patient had a FFR, and most of the pullback gradient was on the proximal. And now Andre is going to show you the LAD, the LAD IVUS.
So
Wait, Andre.
starting from the distal part of the artery, we can see that also the LAD is diffusely diseased. And here we have a segment which presents a plaque that's inferior to 50%, quite around 30%. And then if we go further towards the proximal part of the artery, we can see there's severe calcium that's more than 270 degrees. And then there's like there's a really long lesion, some more calcium. And at the proximal part of the artery, we can see there's a fibrous plaque from 6 to 12 o'clock. And actually the artery, the lesion is quite long, like I was saying, up until to the really proximal part of the artery. The only part that has a plaque burden less than 50%, it's the ostial, the ostial LAD. And then if we advance to the left main, we can see around between 1 and 2 o'clock, there's a calcified nodule that's present up until into the ostium of the left main.
Yeah.
So it's really
The size of the left main seems generous, right?
Of course, yeah.
It's 5, almost 5. So, I think, like you say, Nicolas, calcium is really under-evaluated, especially in old patients. The question is, where do you put the threshold to use a calcium modification tool? I think here, even if it's not the most extreme calcium that you can have in a patient, I think it's useful to use calcium modification technique because it's tortuous, because it's long. We would have been thinking of using orbital atherectomy. We have all the 4 tools for treating the calcium in the cath lab. So the rotational, the orbital, the IVL, and also the cutting. We can combine those tools, but in this case, we were thinking about using orbital atherectomy. And also the IVUS is quite useful to determine the lesion length. There is some area of the artery where there is no plaque. So I was thinking about implanting 3/0 stent biofreedom that can be put up to 5 or 4.5 in the left main, a long stent that we will modify from distal to proximal. So that is the strategy. And so far, patient is doing good. We have an ACT that is above 300 and ready to go. What do you think of our...
All right. Yeah, so I like the strategy. Obviously, you did an evaluation, an invasive evaluation of your LAD, and it's clear that at the transition from the mid to the proximal segment, there seems to be a napkin lesion, almost 360 degrees of calcium, but it's very focal. And then more proximally, there is like a 180-degree arch of calcium. So yes, it makes sense to at least consider calcium modification. The question is then with which tool? And then I believe that this napkin lesion, the lumen of that napkin lesion was quite small. So you might run into trouble here with intravascular lithotripsy. So I think an atherectomy technology makes sense to me. Mohamed, what would be your approach here? Do you see it differently?
No, I like the way you are describing it, Nicolas, because I mean, of course, we don't have hard evidence to help us in choosing different advanced lesion preparation tools for these heavily calcified lesions. And we probably agree upon that there are certain criteria that probably would drive us to use something special, which would be atherectomy, IVL, or whatever, like something different than usual non-compliant balloons. And we have angiographic tools to determine this. We have IVUS tools to determine this. We have OCT. So they didn't IVUS, and you have a high score because of the napkin ring calcification, also because of vessel size, and because of the length of calcification. So probably this would be something where you need advanced lesion preparation. I also agree with your thoughts about lesion length here, which is probably a driver more to towards an atherectomy-based technique. Probably, maybe IDL would struggle a little bit. I don't have experience with the newer version yet, which will be probably available in Europe very soon. I don't know if you have experience with the Aero. We don't have it. It's supposed to be like more deliverable. But because of the length and tortuosity, probably I would go for, in my practice, for rotational atherectomy, but I think orbital would be nice. But I have one question, because I didn't see the angiogram maybe quite well, and at least on IVUS, I didn't see a big narrowing of the left main. So apart from this calcified nodule, which was obvious to me, but the left main looked big, or did I like?
Yeah.
No, I agree. There is no
That's-
disease. Yeah, there is no really disease on the left main. The thing is, even if the proximal ostial LAD is not so much disease, the plaque starts very soon after the ostium of the LAD. So my fear, I'm not sure I can nail really the ostium of the LAD. You know, the circumflex ostium is very clean. So in this situation, I would have preferred to stent the left main, and then after give a pot and the kissing. In case you have some plaque transfer to the left main.
To avoid any swift of.
I mean, looking now at the angiogram as well, I mean, it's always important also to have a look at the angiogram. I underestimated this tortuosity a little bit of the LAD.
Yeah, it's quite tortuous. Yeah.
So, this is something that, at least for rotational atherectomy, I would say could be problematic a bit, depending where the plaque is, and if it's on the inner or outer curve, and where the wire bias is going to be. So it could lead to problems with rotational atherectomy. We don't use orbital, so I would be happy to understand your view on orbital in this case. Is this an advantage for orbital then, if you have this sort of tortuosity?
Yeah, exactly. I think with orbital, maybe you have less wire bias than rotational. So I think also it's an advantage. Also, the thing is, the plan is to cross the lesion using the vapor glide and go back. So I think it's a bit less aggressive for the artery. The artery is very sick, very diseased. You don't want to have an extensive dissection. So I think for this kind of very fragile artery with a lot of tortuosity, maybe orbital is a bit safer. But I think the most important is the wire bias, because you could see that the calcium was not totally ring at some point. And I guess I wouldn't have been using a 2.0 burr. I would have been using a 1.5 burr. So I think the orbital may give me a better result. The only thing is with orbital, I have the feeling you have less the tunneling effect, and sometimes it's a bit harder to deliver the stents compared to the rotational, where you have really this tunnel effect, and the stents are really sliding down very easily. Is that answer a bit of the was it your question, Mohamed, or?
Perfect. So, and this shows us again what Nicholas just said. I mean, I still believe it's very important to do trials and compare devices.
There is lack of evidence.
The question is, what are the endpoints of interest? And we have so many patterns and so many variables that influence the success or failure of a certain strategy, and they will never be covered in an like all or none trial, or like A versus B trial. Correct? We commonly need to also combine all these modalities.
Yeah, I totally agree. It will be very, very hard to have a trial given the number of patterns. So now we have the Viper Glide that is distal. To be honest, the Viper Glide is a bit better than the Rota wire. So usually I don't use a microcatheter, but in this case of tortuosity, I exchange my cyan blue for the Viper Glide using a microcatheter, just to be really well deep-seated in the coronary, and for the sake of time. But the wire, the Viper Glide, you can use as a warhorse almost. On n'avait pas dit de préparer la fraise? On n'avait pas dit de préparer la fraise? So now we're prepping the device.
I think
so that we agree that,
Anyway, may I make just a small question? I think you can use different tools here, and probably most of them will work somehow. So at some point, it's always the operator experience to decide which is the one that he prefers, because there is a question that we don't discuss much, which is, what is the most easy to use tool that you have in your hands regarding all these different calcium therapies? And in this regard, because this is a very long lesion and a small vessel in the body, not a small vessel, but a very diseased vessel, what do you think about this? Would you, if you had to rank the several options regarding the ease of use for the operator, how would you rank it? Which is one that you prefer? Is this orbital or is it different?
Honestly, I'm a big fan of rotablation, because I think it's tools that can be used in most of situations, especially if you have the non-crossable lesion. So rotablator is really a must in the cath lab. And honestly, there is more and more patient and STEMI patient where we use it ad hoc, because you start with a balloon. It's you see it's going to be complex, so a lot of calcium. So I think rotablation is really a must. And if you do here in your cath lab more than 100 rotablation, you know the team is very trained, and it's very easy to plug the rotablator and go with the rotablation. We have an experience with the orbital. You know, orbital is a bit the new kids on the block. It's an area where there is a bit of hype, to be honest. But I totally agree with what you say. You can treat the patient differently. There's been a lot of hype on all those devices.
Very good.
What we try to do is to have what we think is the best device for the patient, and try to combine them and to have every device available. But actually, it's really rotablation, cutting, IVL, and in France, the orbital experience start a bit later than other European countries. But no, we have it on very regular basis, and from some patients like this one, it proved quite useful. But that was a question you're asking. There is no clear data, and it's a bit the experience of the center and the operator. I agree.
So before you go in, you have to make sure that the handle is all the way pushed back, because I see that your orbit is all the way in the front now. The green dot on the
exactly.
device.
But we're gonna cross the lesion using the VaporGlide, and we're gonna go back, to be less traumatic.
Is that okay?
So it's the opposite of the rotablation, where we start to have the knob at the distal end of the patient. So now we're gonna start. So vas-y, point fixe, bien tendu, s'il te plaît. Elle est pas tendue là.
So the advantage of orbital atherectomy is that you can treat bidirectionally. So rotablation is one direction. You only can burr forward. With orbital, you can go back and forth. That has some advantages, especially for osteal lesions. That can become very interesting. And Mohamed already mentioned the wire bias issue that predominantly is an issue of rotational atherectomy. It's less significant with orbital atherectomy. And in very tortuous lesions, orbital might be a little bit more, might have the edge in terms of user friendliness. But let's see how it goes here.
Ok, donc on va avancer la fraise en usant on se met en pure glide.
Yeah. So we go in a DynaGlide mode.
DynaGlide, okay. We can, vas-y, tu peux, hop. Et on va accompagner-moi.
Yeah, so that will stabilize your guiding catheter.
I advance. Yeah. I advance in VaporGlide. Okay. I switch to the low speed mode. Okay. And now I can go back. It's opposite from the rotablation. So I start. You can do the system is activated for 30 seconds. And you hear the beep at the like 5 seconds. And you have 10 seconds to stop it. Okay. So I activate.
And the recommended rate is 1 millimeter per second. So it's slow movement, no rush. and let the orbit do its work.
C'est bon, François?
Benjamin, are you considering doing imaging after this run of orbital atherectomy?
Yeah, it was my, if you have time, for the sake of time. So you
Yeah, we have
to lock
time.
the wire,
No worries.
and and so it's different movements of the ablation. It's not the picking motion, it's really the slow movement. So you can see I'm going back. Okay, so there is a very good hemodynamic. And
yeah, so if you want, you can give contrast. There is potentially theoretically less distal embolization with the orbital atherectomy. Obviously, that has never been shown in head-to-head comparisons, but there are some theoretical advantages with this kind of technology relative to rotational atherectomy.
I agree. What I can say, I had less heavy block on the right, so I don't know. Just
maybe an indirect sign of embolization.
So I can give a little contrast if you want to see there is no perf and no issue. Okay, so you can see no special issue.
I assume you're using the low speed, correct? Maybe you want to comment on that? Yeah.
Well, the low speed is treating a lesion up to 3.5, so it's quite rare to use the high speed. Definitely here it's not the case. It's better to use first low speed and then go to back higher speed. At the risk of perforation increases a little.
Yeah. And in principle, there is one device that covers all sizes. And the high speed typically is recommended for like larger vessels that have a straight segment. You don't want to use the high speed when it becomes tortuous or in smaller sizes. I must say, in my experience, I've never used the high speeds. I've never had the need for it, for the high speed. So in principle, it's and there is only one size of the device, right? So it works. So that's the concept of the orbital atherectomy. It is like this diamond that is going around the inner lumen of the vessel, and by hitting the lumen, it shaves off the calcium.
Yeah, exactly. So it's very rare to use the high speed, but I guess sometimes if you have a big right ostia after the low speed, we did use it a couple times, but often. So this is the third run of orbital.
Yeah.
Fourth. So this is the fifth. Sorry.
So the maximum number of run, Benjamin, it's 10.
Yeah, you get 10 run.
Okay.
But you have to count them. There is no. I'm going a bit more distant.
But okay, every passage is count as a run, right? It can be an antegrade and a retrograde.
Exactly.
So I think you already. I mean, if you were able to negotiate and pass that napkin lesion 3 times, I think you're good to go for.
Yeah, I think fifth run is a good thing. And now we're gonna take off the device, and you can use the Viper Glide. So you release the brake.
Yeah.
You put yourself in Viper Glide. You activate and you go fix and release. Just one thing,
We don't have any
knob is locked.
any head-to-head comparisons for the same lesions, but I wonder which one would spend more time, the rotablator or this one? Do you think that if you were using rotablator, you'd be already done? My question.
Honestly, I don't know. It's really depending from one patient to another. I think with atherectomy technique, the time you're losing doing the point fixe rotaguement.
Usually
And there's also the setup, right? The setup of the orbital atherectomy is a little bit more straightforward than the setup of rotational. It takes a little bit more handling, rotational atherectomy. I agree with you, the burring itself goes faster. You can do burr at a faster speed of 1 millimeter per second. That said, I've become more and more like, why stress? So also when I do rota, I'm not going to go like 20 millimeters per second. Why would you do that? Just let the burr do its action, and why take the risk of the burr getting stuck in calcium?
La CT, il était à combien, s'il vous plaît?
So timing is not really an argument.
And we are already saving time when we perform these techniques, because usually if you don't do them, you're going to end up with a longer procedure. And then anyway, I
that's
think
a good comment.
The threshold for performing these techniques is the point that we sometimes don't have it. We try to make it simpler, and then in the end we get it more difficult when we avoid to use these techniques.
Yeah, agree with that.
We perform the angio after the orbital.
So we complain the heparin because the SCC was too...
SCC is under 300, so I give a bit of heparin, and we are radial, so we can keep to an ISCT.
Yeah.
And of course,
what's the next step? We're going to exchange the wire again?
Cat lab.
Yeah, I will exchange the wire because, it's a long wire, so it's a bit unpleasant to use a long wire. So I will use my microcatheter and and exchange for a workhorse wire. That would be a cyan blue. And one thing also, you had a discussion for IVL. The IVUS it was difficult to put the IVUS down in the LAD. So I think the balloon would have been difficult to. Ça va le patient? Ok. On peut lui faire 2 de morphine. Allez, s'il te plaît, un ballon de 2,5.
Yep.
So I'm putting back my cyan blue that I use for the IVUS, and now I'm gonna exchange, and I will do a trapping with 2.5 balloon in my 7 French catheter. See,
okay,
my cyan blue down.
I mean, these vessels, more or less small, tortuous, calcified vessels, are the ones who tend to make problems if you aggressively use a balloon-based strategy from the start. Like if you start dilating here with non-compliant balloons that probably will not expand, and you become more aggressive, this is when you really start getting problems in these types of vessels.
Ballon, Guillaume, ou pas?
No, not yet.
Yeah, you can get extensive dissection in this patient, I agree.
Okay. 8, hein?
14, vas-y. 14.
Okay. So trapping technique.
Trapping technique. Okay. We flush the EBU. And now we're going to run an IVUS. The patient had a very slight chest pain, but no ECG modification. Hemodynamic is good. No evidence of embolization.
So maybe just for the audience, the trapping technique, you were using a simple balloon to do that. So what you do is you walk out your microcatheter, and then you bring in parallel to this microcatheter, you bring in an over-the-wire rapid exchange, a small balloon, 1.5 or 2.0, just distal from the distal point of the microcatheter. Then you inflate the balloon, and then you can just pull the microcatheter out.
Exactly.
So it's very elegant. 30 seconds, super fast.
Just the only thing is to flush your catheter, because when you deflate the balloon, you may have some bubbles in the catheter. So it's the only.
Yeah.
But you can see that the IVUS is going quite smoothly. I'm gonna keep the IVUS there. So let's do another run. We can see.
So let's now focus on that napkin.
So this is a bit faster, so we're gonna review it after.
Yeah, but I think I saw some cracks there.
Sorry. I can advance the IVUS again. Vas-y, remets-moi en live, s'il te plaît. I will just put it. Okay. Manual. Let's see if there's some cracks.
There. You had at 3 o'clock. You had a.
Yeah,
you had fractures.
Yeah. Okay.
Nice.
So I think we can give some non-compliant balloon to prep the lesion. Let's use a 1-for-1 balloon. Je peux avoir un ballon de 3,020 saphir. So I will use a 3.0 saphir non-compliant balloon, but I won't go to super high pressure. I think I would see the expansion of the balloon. And if at 12, 14 atmospheres, the expansion is good, I think I will keep it that way.
At what point you want to use a cutting balloon, Benjamin?
Well, I think cutting balloon is a good tool because it's not as expensive as other tool. It could be a good adjunctive tools. Now we have balloon, we're using the average balloons that can go up to 20 atmosphere.
Okay.
And honestly, if I had one resisting lesion, I think I would have been resorting to cutting.
Okay.
But the fact that you have now also confirmation of some fractures, that also makes it less necessary to add additional euros to the procedure.
But you're right.
Just go with your regular non-compliant balloon.
Yeah, we discussed previously of the different technique and also the data that we have and the possible RCT. I think to phenotypes better the calcification, specifically with intracoronary imaging. It's super important. Maybe we need to more specify the different burden of calcification.
Mm-hmm.
I think there's been some debate around is IVUS compulsory or is it optional with the recent application. In this case, we have impression that the IVUS is really helping us debate to assess the lesion and what is the landing area. So in this case,
so
I think the IVUS make my procedure more.
So that's an interesting discussion. You're referencing the IVUS chip trial, which was a randomized controlled study from Rotterdam, where we looked at the benefit of systematic invasive imaging, and we were a little bit surprised to find no benefit there. As a matter of fact, there was almost a signal that IVUS resulted in worse outcome over time. You know what? The very important remark related to that trial was that the uptake of pre and post dilatation in the control arm was very high, was more than 80%. And that means that the quality of the control arm was very high. And this was also different with the South Korean trials that we are familiar with. Those trials suggested that IVUS is mandatory and makes or results in better outcome than standard of care. But that standard of care was so different from the standard of care in IVUS chip. So I think what we also as operators need to start doing is be more methodological and as you're doing, respect the PSP principles. So pre-dil, stent, post-dil in all your cases.
Yeah.
Obviously, you need to keep your wire distal. That's important.
Yeah.
Are you using a body wire? Is that what you're doing? Or, no, you're putting a wire in the circumflex.
Yeah, exactly. Because I'm going to stent the left main. So
yeah.
I like to put my, and also, it prevents I have a bit of dampening of the pressure because my catheters goes in the LID. So adding a wire in the circumflex, it prevents to intubating too strongly to deeply the left main. So sometimes I use so we can do a little angio to assess the proximal. So no perforation. I think with the balloon we have a nice result. If you agree, we don't want to do furthermore preparation of the lesion, and we would like to implant the stent.
Yeah. I must say that the only thing that I would do differently here is I would consider staying away from the left main. I think you would be okay. Mohamed, what do you think?
Yeah, I mean, this was my feeling from the beginning a little bit, but to be honest, I cannot exactly see, at least maybe like a caudal view, how the landing zone in the LED would look like. If you still have space.
So guys, can you make a good spider view maybe? Because this is a caudal, this is a caudal.
Yeah. The thing, I have to confess, I'm not very good at nailing the ostial LED, and sometimes I like, oh my gosh, I should have been stenting the left main, but maybe my threshold is too low for stenting the left main, and the left main is very healthy. So I agree with you. I will try to find a good landing zone. And also the angulation is pretty good now for doing... What do you think? I can
it doesn't look even that you have to nail. Like, I mean, maybe you can even stop like a little bit distal to the ostium. How did it look like on your last IVUS? How did the proximal LED look like in your last IVUS?
Yeah, we'll take a look on this part in intracoronary imaging. Yeah.
I think also you said a great point. I think IVUS is very useful to assess the result of your preparation, and also when it's considering bifurcation, sometimes it helps modify your strategy.
So
I
Andre,
think
can
would
you
be
comment the proximal part?
The angle is favorable.
So this
in that regards. That is the only.
Andre.
I think we have quite some artifact on the proximal part of the artery, so maybe difficult to tell. But we saw at the beginning, normally there was only a small portion that had less than 50% plaque burden.
Here it's very, very healthy, the artery. So, okay.
We can maybe try.
Yeah.
I mean,
The goal of IVUS can modify our strategy. So let's go for stenting the proximal LED.
Okay.
I will use 2 projection to assess the placement of my stent.
I mean, going back to the trials, Nicholas, you just mentioned. I mean, there have been so many discussions and arguments trying to explain the findings of the trial. Some of these were even a bit paradoxical. But I would say that the main thing, and you mentioned it briefly, is that it's not that the IVUS arm was like bad or suboptimal or whatever. I think the IVUS arm was fine and nice and everything, but the angiography arm was good because these were just very experienced sites and operators that probably are also trained after many years of experience with intravascular imaging. Their eyes have been somehow trained, and they know exactly what to expect and probably when to predilate, postdilate, and also when intravascular imaging is necessary, when it has to be used, and when you can even maybe skip it and end up with a nevertheless successful procedure with good outcomes. So, and this is, I think, different than in Asia, where operators by habit are like used to just applying intravascular imaging.
So we are now with the stand in. Just want to make sure with the panelists that the position is.
I'll give you a quick quick cine in a spider view to assess the position of the stent. It's a biofilm stent, so the dot is a bit outside of the stent. It's not exigence. And in this style, it was.
I like it.
Okay.
Yeah.
Yeah. I agree to inflate. Okay. Vas-y. Progressivement. Slowly, we already at 14. I can give a little puff to see the. Okay, so no severe plaque shaft to the circumflex ostium. I think I'm gonna give 30 seconds.
Okay.
Do you inflate one time 30 seconds, or do you inflate twice 15 seconds?
Mhm.
I do once 22 seconds.
Exactly what we did. Thank you for answering this important question. No, it's the dynamic was good during the inflation.
But it's very important to stress that you cannot just release a stent in 5 seconds, because this is critical in these long lesions and calcified scenarios.
Yeah.
So now I will give a 3.5 pulse dilatation with non-compliant balloon. I think it's mandatory in those long.
How was the tactile feeling? How was the tactile feeling when you crossed with the stent? It was easy to go?
Easy. I was quite surprised because the IVUS didn't run that smoothly, and the stent went much more smoothly than the IVUS. So it went really quickly, even if it was a long stent of 36 millimeters.
Mm-hmm.
So
Your support is very good.
Use the biofeeder, correct?
All right, I didn't hear.
Is this like your default stent, or what's the rationale of using a biofreedom?
The rationale is, this is an HBA patient. I know most of the stent have data about 1 month.
Yeah.
It's a patient that has apixaban for IF. So this patient, I would be able to do maybe a shorter depth. So this is the first reason. The other reason is that I think I may have to stent the left main, and this stent has a good deformation. The 3.0 can go almost up to 5. So that was also the reason to use that stent. Those 2 reasons. Vas-y, gonfle là.
Okay.
And then for how long would you give him clopidogrel?
We're doing 1 week of aspirin, and usually, if the patient tolerates it, we try to go up to 6 months of clopidogrel inflation. But it can be shortened to 1 month of clopidogrel if there is some bleeding issues. The inflation.
Yeah, so I must say that I dropped the aspirin altogether. I never discharge patients on triple therapy. No.
We still do 1 week.
Yeah, me neither. So I don't give aspirin as well. I agree with you.
Yeah, me too.
So the patient have been pre-treated for 2 weeks for clopidogrel because we did a circumflex stenting. So rolling this patient, I think we don't need to restart the aspirin now. We stopped the apixaban for just 1 day. We didn't took the apixaban yesterday and this morning because we did the orbital and we like to stop it. But most of the patient we keep the apixaban. I don't know what's your attitude.
Yeah, I do the same thing. I stop the day before also because otherwise you have to give some heparin. So DOAC is not enough for a PCI procedure. And then you get a little bit confused with all that. So I stop it the day before and then give full dose of heparin during the PCI procedure.
Exactly what we
Keep it simple.
Okay, back to the IVUS.
Yeah, back to the IVUS. You can see the stent, no edge dissection. Expansion seems quite nice. And let's have a look at the ostium.
What there, yeah.
Okay.
Oof. Perfect.
And how many atlases did you go with the?
We went a bit down the stent. It was your question. We know that the distal LAD
was wondering-
is diseased. Yeah. We just assume the landing zone, the dissection, the landing zone. But I agree that the distal LAD is quite severely diseased. But we decided in this patient to treat the proximal lesion, and if he still has the angina, we could treat the distal lesion also later.
Yeah. And we keep in mind that the FFR drop
Yeah.
was at this level of the LAD.
And I think you really nailed the LAD ostium as you wish to. So yeah, this is a successful nailing of the LAD ostium.
So there is someone in the audience who even suggests, well, the angle of the left main is favorable to maybe also of what you could have done to ensure that you're nailing the ostium is to put the IVUS in the circumflex into the LAD and then do your stenting of that ostium or proximal LAD. There's several, that's a way, a technique that you can do. But obviously, you will need a 7 French sheet for that, a 7 French guide for that, and it may make things a little bit more complicated. But this looks very nice by Anju.
I think I can take with the wire, get a bit of nitrates, and let's resume the case. No, what do you think?
Yeah, well, there is obviously distal disease. We discussed that up front. What is your approach there? Is this something that you're comfortable leaving behind in an 85-year-old, or would you feel it necessary to also go after that?
I think it's a patient that will have a follow-up. So just doing him a basic stress test on a treadmill, and if he's still symptomatic, I think we can treat it. The only question, what I don't like, is when it's super severely calcified. When you have treated the proximal, it's difficult to go back with rotablation on the distal because you have the fresh lymph node stent. Here, I think maybe using a guiding extension or something, I can be able to treat the distal if it was really a clinical issue.
Yeah. And again, you also did a PPG. And there was definitely a jump of the gradient in the proximal segment of the LAD, right?
Yeah, exactly. That was one of the arguments not to treat the distal.
Yeah,
but you're right. Yeah. Maybe you will need to be treated on the. So now you have a good flow. I think I didn't do anything on the distal LAD. I think we can close the case. We check there is no dissection. The expansion is good. The position is good. So I suggest, do you have any other element? Yeah.
Well, we could consider hybrid therapies. Is this a potential target for drug-coated balloons here? And are you adopting these hybrid strategies, combining drug-coated balloons with stents in the same procedure?
To be honest, since I have the drug-coating balloon, I no longer implant the 2.25 stent.
Mm-hmm.
So when it's a long distal lesion, the thing is, I think in this calcified lesion, you will have to do quite an aggressive prodilatation. So you might end up with some severe dissection, flow limiting, that may need some long drug-eluting stent in a small vessel. So yeah, I love drug-eluting balloon, but sometimes this kind of lesion, like to say, Mohamed, you have to prepare quite aggressively. You might end up with a stent, and that was what you didn't want on the first.
Yeah. Well, and this I think is a very important comment, because you deliberately also wanted to prevent massive dissections, right? For that reason, and that is why you opted for a careful, subtle calcium modification with orbital atherectomy rather than with aggressive ballooning or with larger sized rotablator. So I think it makes total sense that with the process that you're having, you are also preserving the distal segments of your vessel. So there may be no need then to end up with full metal jackets or maneuvering in smaller vessel distal LEDs. Yeah. That same question then to you, Rui, is how are you adopting drug-coated balloons in your practice these days? Is it Is it a standalone treatment? Do you use it as a hybrid strategy with stenting in the proximal segments, drug-coated balloons for the smaller vessels, like Benjamin is alluding to?
What I like really drug-eluting balloons, it makes complex simple. When you have a trifurcation, sometimes you're happy to have the drug-coating balloon, because if you're lucky enough to have a good result, it makes complex simple. And for diffusely diseased distal lesion, I think it's really much better than a full metal jacket. We know that we can tolerate dissection when there are no flow limiting. Sometimes I am a bit uncomfortable with leaving a severe dissection, even if the data are quite convincing. I think maybe we have to think of lesion prepping also in drug-eluting balloon. Maybe it's a bit different than lesion prepping in drug-eluting stent. So for now, I have it on the shelf. I use it every week, but I'm quite conservative. So it's narrowly, severely diffuse distal lesion when I don't want to do full metal jacket. And sometime when I want to make complex simple, but still in large vessel proximal, the stents are doing very good. So I didn't totally switch my practice to a drug-eluting balloon.
And Roy, what is your vision on it?
I think in our experience, we all started doing small vessels, diffuse disease, etc. But this has changed clearly with the evidence and the current platforms. And now we are moving towards large vessels, proximal vessels. And of course, for instance, a good example are the bifurcation lesions, where we can of course do an hybrid approach with the stent and preserve the diagonal or branch with a coating balloon. But I think what is important from my point of view is that although the DCBs changed the complexity towards a simpler approach, it doesn't mean that the procedure is more simple from the operator point of view. It's even more demanding, because you have to use all the tools that you have in your box to ensure that you have achieved a good preparation of the lesion before you deliver the drug. So for me, it's very important to understand that if you want to change for larger vessels, you are obliged to be even more perfect regarding lesion preparations. Otherwise, it may have compromises. And I think we all understood in the early days, we were used to see lots of dissections that we left behind. And now we are again in that momentum. We sometimes did dissections that are therapeutic dissections that we can accept, and that was not the scenario in the last decade before we entered this DCB area again.
Yeah. Benjamin, there was also, and Guillaume, there was a question from the audience. What is your take on hybrid strategies with surgery? So do a off-pump Lima to LAD and then take care of the other lesions with PCI. Is this something that has been adopted in Bordeaux, or are we just talking about it and not implementing this?
A lot of patients are discussed in our team. So the question of hybrid strategy is discussed
every week.
Every week, I would say not every day, but every week. We do it, especially for the right. We also have a robotic program, so the surgeon can put a robotic Lima that is quite elegant, and we can treat the right with the stent. If the question is it better to put SVG or a stent? I think it's really better to put a stent. The question is when you have a lesion on the diagonal, or especially lesion on the circumflex, or lesion in the left main. Sometimes we prefer to have a full arterial surgery. But for right, we moved quite a long time ago to the hybrid strategy, and really to avoid SVG graft or allow the patient to enter the robotic program.
Yeah. So this patient received quite some lesion modification and then stenting. What's the plan? Is this patient going to be discharged today, or will you keep this patient overnight?
It's 3 p.m., we have to keep the patient at least for 4 hours. Usually we do discharge on the next morning. We keep the patient one night.
Yeah.
But we have an ambulatory program, and we do complex rotablation, bifurcation, implant cerebral CTO on ambulatory setting with same-day discharge. This patient, he will stay one night at the hospital. Also, we gave 120 cc of contrast, and the radiation was quite low. So for the patient was less than 1 gray.
Okay.
So I think we could do.
All right. Okay.
No resistant question.
Yeah. All right. Thank you very much, Benjamin. Thank you very much, Guillaume, for another excellent presentation coming from Bordeaux. And this is basically the last presentation, the live case presentation from Bordeaux. But to the audience, stay tuned for more live case demonstrations from Copenhagen and for some interesting discussions and case demonstrations of the treatment of pulmonary embolisms. With that, thank you very much to the team in Bordeaux. And also thank you very much, Louis and Mohamed, for doing this with us.